Good morning, everybody, and welcome. Welcome to the Retired Living True seminar series. And today's topic is dementia, avoidable, treatable, or reversible. And we'll talk a little bit more about that in a moment.
I'm Annette Janelle, and this is Brett Janelle. We realize that we have been doing the Retired Living True seminar series. It'll be 9 years. 9 years in June, yes. Thank you. Just out of curiosity, how many of you have been here since the beginning? 9 years. Yeah, quite a few.
Wow.
We started in the library, actually, and now we're at the convention center. It's pretty amazing. Every single month, we choose a different topic. And the reason why is Brett and I are real estate agents, and I've been licensed for 20 years. And we focus our business on helping people downsize. And through that process, we come across many different people, and there's one couple that really stands out in my mind where the husband and wife were planning on moving into an independent living community, and she had dementia, and they waited too long where she wasn't able to make that move anymore, and they had to change gears. And so we are big proponents of planning ahead, knowing what your goals are, knowing what's available for you. The husband at that point had to make a reverse turn and make a big decision for the family on his own. So I'm glad that you're here. I'm glad that we're talking about this important topic. It affects so many people, and it's really quite obvious by this big crowd that we have. We had 230 people RSVP for this event, which is amazing. Yes.
I'm just curious, show of hands, who's here for the first time? Yeah, very good, first time, yeah. Welcome to all the new people. Also, show of hands, who's here for the seminar on dementia? No. Yes? Good, okay, we're all in the right room. Fantastic. So we have some amazing panelists today, and I'm going to have them come up and join me in just a moment. But for those who are new, the way this will work is we've prepared some questions on your behalf of the panelists, and I'll ask those of the panelists for the first 55 minutes. And we'll ask you just to keep quiet during that time. If you have questions, you'll see there's a section in your handout to note down questions you may have of the panelists. And then a little bit after 11 o'clock, we'll open it up to you, the audience, to ask your questions of the panelists. Please keep your questions, how do I want to word this? Yeah. If we can just keep it to questions versus comments or stories. There's a lot of people here. I'm sure there's going to be a lot of hands in the air. I will remind you again. And we'll try to get through as many questions as we possibly can. So if I could have my panelists come up and join me. Come. Maybe if I could start with you, Claire, once you turn on your microphone. Could you perhaps introduce yourself to the audience, where you're from and why you might be on today's panel?
Yeah, absolutely. Thank you so much. And thank you all for having us here today. My name's Claire Day. I'm the Chief Mission and Program Strategy Officer with the Alzheimer's Association Northern California, Northern Nevada chapter. And I have had the honor of spending the last 24 years at the Alzheimer's Association preparing caregivers and people living with dementia for their journey, but in recent years, really looking at how risk reduction strategies may have an impact on brain health, most recently through a U.S. Pointer study, which we'll talk about a little later. So delighted to be with you. Thank you so much for having us.
Well, thank you, Claire. Claire made the drive up from San Jose, I assume last night, was it?
Yesterday morning, yes.
Yeah, just to be here with us. So thank you, Claire. Persephone.
Yes, hi. Hello. Is this on? Yes. Hi, everyone. I'm Dr. Persephone Crittenden. It's wonderful to be here with you this morning. I'm a clinical neuropsychologist at Peak Neuropsychology and Stanford Medicine. And as a neuropsychologist, I provide comprehensive assessments of memory and thinking skills to diagnose and help differentiate types of dementias, as well as other medical and psychiatric conditions. And then I work with other providers and patients and families to help guide treatment strategies. With regard to dementia prevention strategies, I also provide brain health consultations and coaching during which a patient's risk factors are evaluated, and then I put together a comprehensive plan for reducing risk of developing dementia and optimizing cognitive function.
Wonderful. Thank you. Dr. Arps.
Hi, I was here last year. For anybody that was here, we're going to have a good time. I'm positive about this. So I've been in Reno for about 4.5 years. I work at Renown. I also on the faculty at the UNR School of Medicine. A couple things that I do. I direct the neurology clerkship for 3rd and 4th year medical students. I also direct the course on neurology and human behavior for the 2nd year medical students. I see a lot of patients who have cognitive impairment. In fact, most of my clinic are people who have memory problems, word finding problems, concerns for dementia. They may actually have Alzheimer's disease. They may have had a diagnosis for a long time. So my goal is to spend time with people, listen to what they have to say, and put them on the right path. And that often has to do with working sometimes with social workers, behavioral health specialists, because some people have issues that have to do with mood changes, not just thinking and memory. So my goal is to do the best I can for patients.
Thank you, John. Who thinks our panelists might be qualified to talk on this topic? Yeah, thank you all for being here. So maybe, Persephone, if I could start with you, what is the single biggest misconception regarding dementia and Alzheimer's disease?
Well, I think one of the important ones is that developing dementia is a natural part of aging, which of course it absolutely is not. While age is the biggest risk factor for Alzheimer's disease, there's so much that we can do, as we will discuss more today. There's so much that we can do, lifestyle and behavior modifications to reduce the risk of developing dementia and or Alzheimer's disease, which are, of course, two different things. But perhaps I'll stop there for now.
No, perfect. And John, in your practice, any other misconceptions that really stand out to you?
There's so many, but I only have a few minutes. So I'll go to the biggest parts are like what Persephone is saying. So people, I think one of the big misconceptions is Alzheimer's and dementia are the same thing. The number one question I'm asked, they think it's the same thing. The reality is you have to meet certain criteria to say somebody has a dementia condition. I think of it as on a spectrum, almost like in a sense pre-diabetes and diabetes, although we don't really have a number score per se, although we can use neuropsychological testing, things that Dr. Crittenden does to kind of maybe quantitate your cognitive impairments and put you kind of in a specific group of people based on your age and education level. But again, dementia, misconceptions about the diagnosis, what it means to have a diagnosis. A lot of people have what's called mild cognitive impairment. I hope we can talk about that today because they're distinct conditions. They actually can go back and forth. Some people can actually have a dementia issue and reverse themselves to a pre-dementia condition.
So is dementia and Alzheimer's one of the same, or?
No. So dementia is an umbrella term. Dementia, one of the most common causes of a slowly progressive condition of thinking and memory where the person's abilities during their daily activities, which are starting to be impaired, and usually to the point it can get to the point where people need help from another person. That's kind of when we start using a different term, potentially dementia, but we have to do testing. For example, you may have heard of the Montreal Cognitive Assessment, or tests like Dr. Crittenden, which are more extensive multi-hour tests to objectify your impairments. And then we can use all this information as well as a very important thing. I'm going to say this 10 times today. You need to have somebody with you at your doctor's appointments. One of the hardest things that I have to deal with is when a patient comes by themselves. It's really important that a family member or friend comes with the patient because they're the ones that are seeing the changes over time. A lot of times the patients don't have the insight to know what's going on at the same level. It's very common actually where the patient feels they're fine and the family member or friend who's known them for many years is absolutely disagreeing with that.
Thank you. So dementia is the umbrella, so Alzheimer's is just one form of dementia. What are some of the other popular ones, or not popular, but common, I should say, that people would identify with, recognize?
Okay, and I just want to bring this up too. So if you say somebody has Alzheimer's disease, it doesn't necessarily mean you're demented, because Alzheimer's patient, you can have Alzheimer's changes and have a completely relatively normal life. In fact, people could theoretically have asymptomatic Alzheimer's disease based on biomarker testing. Sometimes we will pick up Dr. Crittenden maybe on neuropsych testing where there's a pattern that forms that supports a memory disorder that seems to be in a situation where the person's at high risk based on a cognitive profile, but the person's doing well. So the point is it's a spectrum disorder. So Alzheimer's disease, when somebody says, I have Alzheimer's disease, I understand that as a degenerative disease as a neurologist, but you can have a whole that's why I call it a spectrum. You can be just slightly impaired to very, very severely impaired. People live 10 years, 15 years with this problem. Some do quite well. A lot of people do quite well for the first 5 or 10 years, actually.
Thank you.
Yeah.
So Claire, you're with the Alzheimer's Association. So what percentage of people with dementia would be Alzheimer's? And then again, what are a couple of the other common types of dementia?
Yeah, I think that's a good question. I don't know that I would say the about 60 to 70% of people living with dementia have the Alzheimer's type. And as Dr. Arndt said, I think it's important to recognize that you can have. What's really important about Alzheimer's disease or any of these different types of dementia, like frontotemporal degeneration, Lewy body disease, vascular dementia, the dementia sort of related to having strokes, most commonly thought of as having strokes, is for Alzheimer's in particular, it's a biology, right? There's a biological change in the brain that's occurring well before, as Dr. Arndt said, we see any of the cognitive symptoms. I sort of look at it, same thing as you're saying spectrum. It's that the cognitive continuation, right? So it can change so rapidly. And I think we use the words Alzheimer's and dementia interchangeably. We shouldn't, because they are two very different things. And I think it is important now. Science has advanced for us to really understand clinically what some of those differences might look like, where 20 years ago we really didn't know or have the capacity to know some of those clinical differentiations between the different types of dementia.
Thank you. So what are some of the warning signs that we would be looking out for, whether it's Alzheimer's disease or dementia? Are they the same symptoms or very different?
Yeah, so they can differentiate a little bit. So, for example, for someone with frontotemporal degeneration, we see the ability to lose sort of the word finding, what I just experienced. That sort of ability to communicate. Communicate was the word I was looking for. Fairly earlier on in the disease process, where someone with Alzheimer's disease, the reason it sometimes takes so long before we see Dr. Arts is because we can trick people and cover with some of that automatic speech pattern, with just sort of being able to cover up some of the changes and make them seem like it's just normal aging, where they're covering for themselves. And so typically, memory loss is what we think of as that sort of number one warning sign, right? But what does that mean, memory loss? Really short-term memory loss. So think about what you had for breakfast this morning. Who can recall what they had for breakfast this morning? I hope everybody. Who didn't have breakfast this morning? I think that's a bigger question. Short-term memory, right? Did you take your medication this morning? Did you leave the stove on? Did you put the kettle on to make a cup of tea? Long-term memories, those memories that are associated with sort of, who was your first grade teacher? Who remembers their first grade teacher, right? Long-term memory. So people can say, oh, my mom's memory's fine. She remembers the color of the curtains in our childhood home. What's that? Long-term memory, right? It's that short-term memory that's critical to day-to-day living, and it's why it's one of the sort of most common signs we see. I would also say, it's other things like visual, spatial perceptions, trouble remembering familiar words, familiar routes. I would use the word, though, change. Think about what's different from 5, 6, 7 months ago, a year ago. And if that's a change, that's when there may be more cause for concern rather than normal aging. My mom was great at crossword puzzles, terrible at remembering people's names. So if she had forgotten people's names later in life, I might not have been so concerned. If she couldn't do her crossword puzzle, I would have been.
Thank you. Persephone, do you have anything you wanted to add before we jump to the next question?
Yeah, just I love the change piece. That is super important. And also the way that the changes impact your day-to-day functioning. So yes, I often struggle to find that right word, but I'm still able to carry on a conversation. If the word finding difficulties or the language changes are becoming such that it is difficult to communicate, and you're getting stuck mid-sentence or losing the train of thought of what you were trying to say, then this is, of course, more impactful to your day-to-day function. And so it's normal changes, normal cognitive changes. There are things that change with age. Processing speed, for example, we tend to maybe do things a little bit more slowly and a little bit. There are more of those word-finding difficulties, that tip of the tongue issue with, I know the word and it's just not quite coming. But those things can be a part of natural cognitive aging, and it's different than when these changes are such that it's impeding your day-to-day function. You're getting lost in familiar places. You're unable to find your way home from somewhere that you go frequently. You're no longer able to remember that recipe that you've been cooking for years. So it's the change and the disruption in day-to-day life that really makes the difference between normal cognitive aging and something concerning.
Hello? Oh, yeah. So again, very important to know what Dr. Crittenden just mentioned. A lot of times patients aren't aware that these things are happening. Yes, they will say, I go into a room once in a while, or they don't recognize the frequency of it. I've had people quite often that say it happens once a day and it's happening all day long. So the only way to really know that, and if it's progressing, is to have somebody that knows the patient very well. Preferably, we'll talk about this again, called the durable power of attorney, because that person needs, usually is a legally designated person to make decisions for somebody. It doesn't necessarily need to be that person, but somebody knows the patient quite well, that sees them, preferably if it could be somebody that lives with a person. That information is vital to getting the history about what's changing, how it's changing, the rapidity of the change, and what are the associated symptoms besides memory loss or memory changes.
Okay. So are there any medical conditions that you encounter with patients who come in that look like dementia but are actually something else that can be treated or reversed? Yeah, John.
Did you? Oh, yeah. So there's many, many reversible causes. So if you read on the internet about causes of memory impairment, we'll use the term mild cognitive impairment, which is a specific diagnostic syndromic term, and then dementia is kind of a more advanced phase of mild cognitive impairment. All of those things I just mentioned, memory impairment, memory loss, mild cognitive impairment, dementia, all can be caused by similar issues. For example, alcoholism, drinking too much. Very commonly, I ask every single patient, do you smoke and drink? Some people will say, I drink a little, and they're drinking a fifth of vodka, a lot, and they don't, in their view, that's not very much. Point is, so there's vitamin deficiency states, thyroid conditions, uncontrolled diabetes, medications is a very big one, obstructive sleep apnea, sleep disturbances. I'm just thinking there's a lot, depression, anxiety, especially depression, because if you are depressed to the point where you're not able to hold information in and you have low motivation, it comes across oftentimes as your mind's not able to process information quickly and things don't stick. Your attention's not there. That's very important. In memory consolidation, you have to be able to hold information in to have it stick in your mind. So when people have a depression, especially if it's significant enough, that obviously could be treated, and I've seen what's called pseudo-dementia, people that actually have a very impairment in their day-to-day lives and they're actually depressed, and they could be put on medicines and get psychotherapy and be much, much better within maybe 4 to 6 weeks. So yeah, many causes. This is what I do all day long. I look at medications, I ask questions, there's lots of causes. So I want to exclude as many things as I can before telling somebody it could be something that's irreversible.
How common is it that it's something else?
So I would say 25% at least.
Wow, that much.
It's a high number.
Yeah.
Especially, you got to be careful about over-the-counter medicines. And there's a lot. We don't have time for all this, but I would just say anything that's what's called anticholinergic can infect your memory, even some of the antihistamines. So when you go and get an over-the-counter medicine at Raley's or wherever you're going, be careful if you already have a memory impairment problem, because there are some that have this anticholinergic property that can affect your thinking and memory.
Thank you, Dr. Arts. Claire?
I would just add infections, especially urinary tract infections, can very much present with cognition changes.
Thank you.
As well as hearing and vision loss. And this can, of course, if you're not able to see or to hear well, that can contribute to some social withdrawal and some depression. But it also increases cognitive load, and your brain has to work harder to try to hear something that you're having difficulty hearing. And that also can then contribute to cognitive changes, memory difficulties, attention difficulties. And it's also important to think about the fact that some of these conditions that we're talking about now, including sleep and depression and hearing difficulties, they can present as dementia. They can give the same sorts of symptoms, difficulties with memory, with attention, concentration, or being confused, disoriented. They can also, however, they can be reversed insofar as these conditions can be treated and then the symptoms might improve. But if they are not treated, they can also contribute to irreversible dementia processes.
Can you just expand a little bit more on hearing? I haven't heard that before. So what do we do? What would you suggest if someone is a little hearing impaired, other than probably not good to ignore it, but what would you suggest?
To get hearing evaluation from an audiologist quickly. This can be something that we often think, oh, it's just, again, a natural part of aging, right? And so I won't give too much concern to this, and just hopefully people will speak up a little bit louder, or I might start to miss certain bits of a conversation. But it is so much more than that. Think of it as not just a hearing issue, but a brain issue and an overall health and well-being and longevity issue. And it can be sometimes uncomfortable or even embarrassing, and so therefore we don't want to think about it or address it. But I implore you to please not disregard difficulties with hearing or vision. But yes, we have good data now that shows that hearing impairment, untreated hearing impairment, contributes to cognitive decline and dementia processes.
Thank you. Dr. Arts, you had something
I
you
was
wanted
going to
to add?
mention two things, and it is definitely true. A lot of patients don't even bring their hearing aids, which, I mean, you know, they're going to see a neurologist, but I understand that because they have a memory problem, so they forget it. So if you all have any concern or want to see me, bring your family member or friend, have them write down, please bring the hearing aids.
And your reading glasses.
I don't sell hearing aids, although there's some really nice hearing aid equivalent devices you probably have seen on Amazon for $50. I'm not selling products. I have no disclosure for anything in terms of selling things. But I will say one thing, and again, there is a device that Apple just released pretty recently where you can actually put the AirPods in and do an evaluation yourself. I'm not saying it's probably better to go to an audiologist, but you can actually do a screen on yourself using your iPhone app and change the different frequencies, and it could be a way to do that fairly easily. So,
Interesting. Yeah. Anything else before we move on to the next question?
I would just add, it's also an emerging field of research. There's a lot of scientific research happening to really uncover, is it causation, is it an effect of, or more, yeah, so it's really an emerging field.
Okay, thank you, Claire. So are there any promising treatments coming out or are out as far as treating Alzheimer's or dementia that we would want to know about?
You want me to
Claire.
take that one, Dr. Arts?
Please, Claire, you start.
Dr. Arts and I are going to agree to disagree on this one. So here's the thing. Yes, I think the short answer is yes. We know that up until recently, the only potential treatments for Alzheimer's disease in particular, and when we're talking about these treatments, we are only talking about the biology of Alzheimer's, nothing for any of those other types of dementia that Dr. Arts mentioned. And so those treatments that have been available really have only potentially helped the symptoms. And I think one of the challenges that we have with Alzheimer's or cognitive decline is, unlike things like blood pressure, if you have high blood pressure and you take a medication and your blood pressure goes down consistently, we can pretty much make a good causation that that medication is working. It's doing what it's supposed to do. Not so easy with the brain, right? It's a little harder to understand what those cognitive changes would have been without the treatments. But what was available or is still available in some of those early and moderate stages really only are designed to treat those symptoms. Recently, there have been some advances in treatments to actually address the underlying biology of Alzheimer's disease. They're called monoclonal antibodies, and I will say they are not the magic answer. It is hopeful, right, that we're getting to the point where we're seeing science advance to be able to actually potentially treat the underlying biology. That doesn't come without risks, and it's not for everybody. It's a very small window of people that would even qualify for these treatments should they be available. And I think one of the things that Dr. Arts and I talked about the other day is that the reality is these treatments are not available in most places. You have to live near a big treatment center or a big health system. So there's huge barriers in accessing these treatments. There is some concern as to whether or not the science is there for everybody, because I think it's it's a one-person decision as to whether or not you want these treatments and want to take the risks for them. But I think the message is science is advancing to really understand how to impact the biology of the disease and not just treat the symptoms, which is where I see the hope in these treatments.
Thank you, Claire. Dr. Crittenden, did you want to add anything before Dr. Arts jumps in?
Well, not to disrupt the.
Or do you want to
flow
move so
here.
you're not in between?
But I mean, I think I agree with you, Claire, that these are very exciting developments, absolutely. And I also agree with Dr. Arts that there are significant
As do I,
risks
yeah.
that can come along with these new treatments. I will just put in a little plug for not treatments, but some of the exciting things as far as early detection and reducing risk, because it is true that we have very, very limited options with regard to treatments and with regard to just managing symptoms once symptoms of Alzheimer's or other dementias are present. But so this is why early detection is so critical, because the best sometimes that we can do as far as treatment is to slow progression. And that's going to be done best if identification of a disorder or a process, a neurodegenerative process, is done as early as possible, of course. And so we do have, if you have concerns about your own memory function or your loved ones, go in and see someone, talk to your primary care, talk to a provider, and early detection is really, really key. And thankfully, there are some fantastic new tools as far as digital technology tools, AI tools that are helping to both with diagnostic accuracy as well as much earlier detection than we've been able to do up until this point.
Thank you.
And I think that piece about early detection and biomarkers, which is that biological piece of us that tests and shows that we have evidence of a disease. If you think 20 years ago when we were doing some of the early research in Alzheimer's, those biomarkers weren't available. So I think it is where we're starting to see the science of evidence of that biology really now being able to use in clinical trials to advance the disease, and hopefully now not just for Alzheimer's disease, but for some of the biologies of these other types of disease.
Dr. Arts, I know you're
How
waiting
much time do I have? Okay, cut me off at 10:40, please. So
10:35.
Okay,
You got
shoot,
5.
5 minutes?
Yeah.
So are we talking about Alzheimer's disease now?
Medications.
For Alzheimer's?
Yeah.
Oh, okay. So there's a list. So I'm going to go back to the intravenous anti-amyloid drugs. The first one came out in 2021. It's called Aduhelm. The drug probably shouldn't have come out. I'm just giving you the backstory of what I know very quickly. 3 of the senior neurologists on the FDA advisory committee left that committee because it was approved. The drug's coming off the market. There's 2 drugs. One's called Leqembi. The other one's called Kisunla. Leqembi's a Biogen drug. Came out approved July 6, 2023. The Kisunla drug was approved maybe 5 or 6 months ago, Eli Lilly, so there's competing companies, obviously, because this is an important space. The main point about these drugs is, yes, they do remove amyloid. So there's 2 proteins in the brain that are associated theoretically with the disruption of the brain tissue and the disconnection. One's called amyloid, the other one's called tau. There's different types of tau. You can actually measure this, and there's some companies now, you can actually measure these biomarkers in the blood. But long and short, these drugs go specifically, theoretically, attach or try to attack amyloid to remove it from the brain. The problem with doing that is that in the studies, the Clarity AD study, which was the Leqembi study from about 2 or 3 years ago, showed that about 10 to 20% of people had brain hemorrhages or brain swelling or a combination of both. And it was hard to risk stratify very well which patients had that, although people that were on blood thinners, like even aspirin, had an increased risk of bleeding. Point being that there are some significant risks that Claire was talking about, and those are, we call them ARIA, A-R-I-A, amyloid-related imaging abnormalities, which are brain swelling or brain hemorrhages, and they can be very significant or very minor. There's also something that came out last year, and this is publicized on the internet, that there was accelerated brain atrophy in people that were exposed to these IV anti-amyloid drugs during a 1.5 years of the study, which is kind of concerning. We don't know what percentage now. I don't know why we don't know the percentages. So there's 3 major risks. The benefits are they slow the disease down slightly for about 6 months. So think about Alzheimer's being a multi-year condition. You're taking potentially a very significant risk to your brain to get a small relative benefit. We call it the absolute clinically meaningful benefit. So I actually don't have anybody on the drugs, and I've talked to 500-some patients already and family members. Nobody wants to take the risk. That's the reality. But there's good news because there's drugs coming out and they're being studied. Ozempic and the GLP-1 inhibitors, you may have seen those on TV, Ozempic, and there's a few other ones. They are actually being studied right now to slow the progression of Alzheimer's. You all may not know this, but type 2 diabetics have a high increased risk of Alzheimer's/dementia. It really turns out to be Alzheimer's, and because it's a sugar problem. Stay away from sugar. That's another message. Try to stay away from processed sugar. So there's drugs on the horizon that are being studied. There's also 2 drugs, and I'm just going to mention them, 2 groups, cognitive enhancing drugs. One's called, you may have heard of these, Aricept, donepezil, and memantine, which is, I'm blanking.
A glutamate modulator?
No. I know it's MDA receptor antagonist, but the other name, Namenda, memantine. Yeah, memantine/Namenda. One's the brand name, one's the generic name. So those drugs have been out for 20 years. They don't slow the disease down, but some people, they will stabilize the symptoms. Like I call it a Band-Aid effect, but sometimes it can last for a year. You may have heard of this. You may have had family members on them. I see lots of people that have been tried on them. The primary care doctors, some of them like to start them on them. The point is they don't change the disease. They don't go to the actual amyloid and tau, but they essentially flood the brain and the body. That's why some people have side effects from them, but they actually are putting they're kind of flooding the system that theoretically is affecting memory and sometimes generally thinking ability, and hopefully kind of connecting through chemicals the circuitry for a period of time. Sometimes it's dramatic, most of the time it's not, but they've been approved, they've been on the market, FDA approved for over 20 years. Okay, that's my.
Did everyone get that? That was a lot of
I have 2
information.
more minutes, but I'm going to leave it at that.
Let's talk about the role genetics play. So if I've got a family member, a grandparent, a parent that have had Alzheimer's or some form of dementia, does that mean I'm going to be impacted by it? Claire, would you like to start?
Yeah, it's such a good question, and it's one we get so often, because I think one of the things that we really talk a lot about when we talk about dementia is really its risk. The word risk is so important because we don't know today what will prevent the disease. We don't, and so what are those risks looking like for genetics? So Family history is certainly important. Family history isn't the only factor, though. There are genetic components of the disease that put you at higher risk. But I think one of the things that's been really fascinating to evaluate over the years is that people can have one of the most common genes you might have heard about, or is this APOE4 gene. You can have 0, 1, or 2 copies of this gene. And one would assume 0 puts you at the least amount of risk, 1 more, 2 the most, right? But it's not the only answer. It can certainly increase your risk, but we know plenty of people who don't have that gene who have Alzheimer's, and people that have the gene that don't have any cognitive symptoms. So it's important to understand that there are risks out there. We talked about age in the beginning. The biggest risk factor that I think we really have in the room is age. But certainly genetics and family history play a role for it, and is why if you do have Alzheimer's or other types of dementia in your family, you should listen to what we're going to close with, because that's going to be the most important takeaway. But I think the other piece is to think carefully about what you're hearing with genetic testing, and really understanding what that means, because it doesn't necessarily mean it's an inevitability. And we're learning that the APOE4 gene, for example, plays a different risk in people depending on their race. And so there's a lot we still need to learn about how genetics impacts this disease.
Thank you. That's good to know, because you could easily go take those tests and decide, okay, genetically I'm predisposed to it, when that may not be the case at all, and then you get depressed, which then leads to other issues, and so on and so on. Yeah.
Pseudodementia.
Say that one more time.
You said you can become pseudo-demented worrying about your APOE4 test.
Right. Yeah. Very good. Persephone, do you have anything you wanted to add?
Just to tack on to what you were saying, Claire, because absolutely it's all about this risk, right? And so yes, genetics or family history can be associated with an increased risk for developing dementia. But the truth is, the majority of dementia cases of dementia onset is not related to genetics, not related to family history, and really there's just so much that we can control that is going to be very impactful in our brain health, and again in reducing our risk. So yes, genetics can play a part in that risk, but most dementias are not genetically, you do not get it because of genetics or family history for the most part.
So what's our number 2? So number 1 is age. We're all obviously aging. What's the number 2 cause?
All of these things that, again, we're going to be talking more about shortly, but not getting good sleep, good, consistent, adequate sleep, and not managing vascular risk factors, and not treating things like depression, not treating all of these things that we're talking about that are modifiable risk factors. That's the number 2 cause.
So lifestyle, would that be the word that kind of summarizes it, that we're going to come back and talk about? Yes. Okay. Dr. Arts, do you have anything you wanted to add?
Absolutely.
Go
Always.
For it. Huh?
So what else I was going to say, so I've been doing this 25 years, and neurology. So even in this area, but I don't think it mattered. I was in the Northern California and the San Francisco area for a long time before I came here. And I'm just guessing, I've seen 15,000 patients that have cognitive problems, maybe more. I would say a handful have gotten genetic tests. Like, there are people out there, and they can go, you've heard of 23andMe, or maybe you can do your own, it's just like the Ancestry.com, you can get genetically tested. But the reality is, even if you're APOE4, and I've seen a few people like that, it all really comes down to lifestyle factors, unless the patient really wants to go deeper, and we can do like CSF analysis and look to see, yes, do you really have more biomarkers to support you have the Alzheimer's pathology or not? But it gets down to looking at your lifestyle, doing things we're going to talk about in the next, hour or so, and everybody's different in terms of what they do. Some people don't walk, some people do a lot of exercise. But I want to put a plug in for anybody who has sleep apnea. Please use your CPAP machine, because if you look, and this is honest, I'm just telling you from my background, I see this is what I do every day, 5 days a week for many, many years. If you don't use your CPAP machine, not only don't you feel well, and you can become depressed, and your memory gets worse, but there is an increased risk of amyloid deposition in your brain from being non-compliant with CPAP. I hate to say that. There's research. There is clear research that happens. So one of my pet peeves is telling people and asking them about sleep, and also making sure as much as I can to convince them to use their CPAP machines, because it's a very common problem over the age of 50, 55. It's like over 1 in 2 people have sleep apnea.
Isn't it somewhere like 35% increased risk? It's a pretty...
It's really high. It's like
yeah.
really, really high. Yeah, it's extraordinary. So that's why I'm saying it's like a really high, yeah. So if you all snore, don't feel good in the morning, or your bed partner, whoever you're with, is saying that you're maybe doing a little kicking, which could be other things like restless leg, you can be evaluated for this. You can be tested for sleep apnea very easily, and it's a treatable condition. And you don't want to be untreated with a significant sleep apnea problem for years and years and years.
So go see your primary care physician.
Absolutely.
Yeah. Wonderful. So Claire, I'm going to jump down to you. So question I have, which I just dropped, is if we have a family member or a loved one who's being diagnosed or living with dementia, where do we go for support in the community? What's available? Where's a good place to start?
Yeah, thank you for that question. And I think, first of all, know that there is so much support in the community, but sometimes finding it is really, really hard. And especially with something like Alzheimer's and dementia, you don't sometimes even know where to start. Certainly, a little shameless plug for the Alzheimer's Association. Of course, we are a great, what I think, first stop, whether it's through our 800 number or through our website or coming to our local programs and services, because while we don't do everything, we're really connected to those community services and can help to refer you out to ongoing support. And I think one of the things with Alzheimer's or any type of dementia, it is a trajectory, and it's oftentimes slow. Dr. Arts mentioned in the beginning, we're talking 10, 15 years on average that people live with dementia. People living with dementia and caregivers and community members helping to support need support throughout that 15 years. And it's going to change. You're going to sort of see a plateau where you think you have everything okay, and then there's going to be a dip in the disease process that's going to create new challenges or circumstances that you need to learn about. So please call the 800 number. I think, is the number up on the screen? 800?
It's on the screen.
Okay, great, thank you. Or just reach out. There's other amazing community services here in Washoe County, throughout all of Nevada, that are really here to support, and we can get you connected.
Thank you. And in your handouts on the very last page, you'll find the phone number and a number of different resources that the panelists have provided. Dr. Arts, did you want to continue on?
Oh, I just want to make actually a plug for that. It's called the Alzheimer's Association and Related Disorders, correct? So
It is, that's our legal name.
Right.
Yes.
So it is
It's just a
important
little
because
long
they
for
do
the
help
business
patients other than people with,
Yeah.
with Alzheimer's. So I just bring that up because it's important, because you all serve a purpose. It's very important, and it's not just for Alzheimer's disease. Okay, there you go.
Thank you.
Dr. Arts, can you make mention of the program that Jennifer Carson, Dr. Carson has at UNR?
Yes.
I think we have a slide.
You
We
can,
do.
yeah, actually, slide.
Oh, you have the handbook.
So actually, Jennifer Carson's a professor of the School of Public Health. I know her. Actually, I think all of us know her. I know. But long and the short, she's given a talk here. Right?
Yeah, Jennifer's been
Yeah.
here several times.
So you can get this online. She wrote this. She's like the lead author a year and a half ago or so. This is the book that came out and that then became digitized. It's a very good primer about memory, thinking, lifestyle factors. We'll talk more about the different issues that happen to somebody potentially who has a cognitive memory problem or a more frank dementia condition, and there's different stages of that. So the DEAR program is something that Jennifer started, I believe, in 2018. It's called the Dementia Engagement Education and Research Program. It's very complex. There's a lot on the internet about it, but essentially she's trying to engage the state and communities and organizations and families people living with dementia, the patient, and the caregiver. And it's kind of like I call it a symbiotic relationship. And so the DEAR program does a lot of outreach. They do Zoom calls quite often, sometimes twice a week, monthly on different topics related to memory, thinking. Sometimes there's behavioral things that happen to people, such as you may have heard of the word sundowning. It's a very complex issue. Some people have very difficult behaviors to deal with, and how does the family member or the care partner deal with that? So she started this. She's a very well-known person, actually internationally, and she's here in Reno. And DEAR is kind of the outreach, and there's other entities that she started here. But this is a very easy book to read. Again, no money. I don't get anything to tell you. This is all educational completely. You can download this on the internet.
And the link, if you do wish to download it, is in your handout, along with a phone number if you want to join their 6-week program. You can reach out to the DEAR program. Other resources, books. You provided us with a list of books, both of you.
I'll do it, and then you'll follow up, please, because we actually agree with most of this, I'm pretty sure. So the problem with all the books out there, there's hundreds of them. It's always hard to know which ones are the best ones. So I usually, the ones on the, some of these books are really new. I will say this, that most of the books are going to overlap in what they talk about, because the reality is it does come down to reducing your risk or slowing the progression. And there's things you can do, every one of you, including myself, whether it's nutrition, exercise, sleep habits, mood, people that have stress, try to reduce stress. All the books are going to talk about that. Some of them are on the website. I will say, to my view, the best book for memory is a book by Richard Restak. He wrote it 3 years ago. He's a neuropsychologist at George Washington, the East Coast, and he's written literally 20 books on brain health topics. It's a thick book. It's not really hard to read, but it's called The Complete Guide to Memory. I think that's an awesome book. And Sanjay Gupta's book that he wrote about 3 years ago, Keeping Sharp, Build a Better Brain, is a very easy book to read about kind of living your life the best you can and trying to reducing your risk. And again, it comes down to lifestyle. And we do have research on this stuff. We're not just making, just like patients who have heart problems, go and exercise. There is clear, absolute research that shows that, for example, and we'll talk about this, the MIND diet, the Mediterranean diet, it reduces risk. It's known to fact. Reducing sugar intake is known to fact to reduce risk. Exercising, known to reduce risk. That's why the World Health Organization, the CDC, have put out specific information over at least the last 10 years about exercise. Okay, I'll leave it at that, because we talked about books, because there's too many of them. They're all good. You have to like whatever you like to read, and then you can always rent one, and don't have to buy it. You can buy them on eBay for $3. Get a good
They're all
deal.
in your handout.
Yeah.
So on the
But
last
anyway,
page,
a lot of these
all
books,
of the
if-
books are listed there.
you can buy them on eBay, a lot of them.
Persephone, do you have anything you wanted to add?
Not
No, we're
really,
good with
no.
that.
It really is.
Good.
There's so much overlap in all of these books and various resources, because they all do latch on to the research that we do have now that shows that these lifestyle factors can do a lot to reduce risk. And so really it's just about finding what works for you as far as the resources and the material, and being able, the important bit, of course, is being able to find what works for you as far as implementing those strategies. Because it's great to read them all and to think about, oh yes, I know that if I get more physical activity, that's going to reduce my risk. I know that if I'm getting better sleep and using my CPAP, that's going to reduce my risk. But actually doing those things, being able to implement them in a way that feels enjoyable and doable, that you will stick with, is really the key component. And so find what works for you as far as the resources and the material, and also just what works for you day to day. And I really like to say that all of these various strategies, they're not all or nothing. It's like, even if you can incorporate a bit more of the leafy greens associated with the MIND diet, for example, into your daily eating habits, or get a little bit more physical activity, these things are still going to have substantial benefits.
Well, I'd like to come back to that in a moment. I have two really important questions I definitely want to make sure we have time for, just looking at the clock. So the first one I have is, what advice would you have for families who are navigating decisions related to dementia when it comes to housing, caregiving, or legal matters? Who would like to start?
I'd say first and foremost, and this is sort of what you two were talking about at the start today, but planning early. Planning early as possible, of course, ideally before you or a loved one are having any type of concerns with dementia. But planning as far as care and living arrangements and finances and health decisions, because avoiding those crisis decisions and uncertainty about what would my loved one want in this case are really, really critical, of course, because that preserves dignity and autonomy and allows everyone to feel comfortable with the decisions that are being made.
So not being in denial, but having those conversations so you're part of the solution or what your future is going to look like.
Yes, and they're scary conversations. They can be scary conversations. But yes, absolutely, just finding a way to be courageous and to say, let's sit down and really talk about what we want and how this should work should something frightening happen.
Claire.
Yeah, I think they are so important. These early conversations are so important. Of course, we're talking about dementia today, but that really applies to everyone who's getting older. We should be having these conversations. We shouldn't be afraid to ask for help and make those plans. And I think when it comes to housing and changes in level of care, that decision has to be made on what is best for the person living with dementia and for the care partner. It's not always it's not a one-size-fits-all decision, and sometimes bringing in help to support the person living with dementia in the later stages is actually the better alternative for housing, as opposed to trying to do it all yourself at home alone. I think that's where we see concern for the care of the caregiver. And the health of the caregiver that can often be compromised because so much is put into the person living with dementia that the caregiver's health and well-being often gets ignored. And we're all here to say, in the community of services that you've interacted with today outside, that we're here to support you in that journey.
Thank you, Claire. Dr. Arts, I wanted you to talk about durable power of attorney and why that's so important.
Yeah. So, and this isn't just for people that have. Yeah. Sorry. I need one of those. You have one of those? No, sorry. So, DPOA, durable power of attorney, is a legal document that's essentially binding that says that this person has been vetted to be my surrogate if I'm incapacitated at some point, to make decisions for me, whether they're financial. There's healthcare directives related, and there's financial directives, kind of the two main reasons, but it has to be kind of vetted by an attorney. It's a document. People go, can I get a DPOA, Dr. Arts, today? I'm like, no, you can't, sorry. But it's a good question to bring up. I pretty much tell every patient they need to be looking at that, especially if they have. A lot of people I see aren't demented yet. They have memory concerns and they're not anywhere, well, I wouldn't say anywhere, but they're not close to the stage where I can use the dementia term. But at some point, I can tell some of these people are going to eventually get there, whether it's 2 or 3 years from now, which is really hard to know what the timeline is for most of these things. DPOA is that document that gives the authority to make decisions, because you don't want to be in what's called a conservatorship situation where the state has to take over and I actually have to fill out documents. I don't mind doing that. It's just more time. I'm not saying that for other person, but you don't want to be in a situation like that where people are making decisions for you that you did not kind of, if you have the time and you thought about this, you had designated, usually it's a family member, but it could be a friend, because some people don't have family left over. It could be a close friend, as long as it's documented. We put it in your health record at Renown. I believe most institutions would do that, so we can see who that person is. And the other point about this is that when you see somebody, whether it's a neurologist or not, and the DPOA has been designated into the computer system, the health record, at least the other people that are, like the medical assistant who's calling, we prefer to call the DPOA for like medication issues or something where the patient can't make decisions for themselves and wouldn't understand what we're saying in the first place to them. That's that designate we can talk to that will make those proper decisions. So,
is there any reason why any of us in here should not have one?
No.
So put it another way, we should all have one?
And also a pulsed. So pulsed is, CPR, resuscitation. It's a pink sheet, I think, throughout the United States. You should also have that, especially if you have heart disease, diabetes, risk factor smoking, or family history of heart disease. And actually, over the age of 50-ish, I would say, a pulse would be useful. They put it on somewhere in your usually on a refrigerator. So if the EMS comes, emergency medical system, and you're unresponsive, it'll say, I want resuscitation, or I don't want it, and it will affect, the downstream effects of whether you're treated, whether you want to be or not. So those are the two forms, really important, DPO and PULSE, P-O-L-S-T.
Who was here last month for the emergency services and we had EMS on the panel? Keep your hand up if you came along to the workshop that we did on completing the PULSE form. Who would like another workshop on completing the PULSE form that wasn't able to attend? Okay, thank you. Awesome. So I really want to spend the last 5 minutes talking about risk reduction strategies. That's what we're all here for. What can we actually go and do to reduce the likelihood of any of us ending up with dementia or some specific form of dementia? Who would like to kick that off? Persephone, you mentioned the mind diet. I think we had a slide because you provided me with some information. Let's talk about that.
Yes, there should be in your handouts what I call the simple guide to the mind diet, because again, this is a lot of information, all of these various lifestyle factors and things that we can control and modify. And even looking at the books, as far as the Mind Diet book, which is fantastic, and Dr. Arts has written the foreword to the most recent edition. But these things...
I got no money for that.
It can be...
Full disclosure.
It can be a bit overwhelming. And so my patients have been very grateful to get this very simple guide that I provide that, again, just kind of shows... eat more of this and less of this. And it doesn't have to be completely overwhelming. But yes, so that's a big one. And then I also just have to talk about sleep again. I know we've all talked about sleep.
Just before you jump to that,
yes,
because everyone's got it on page 2, is there anything specific they should really focus on that mind diet?
I mean, there's so much about increasing your leafy greens, really getting as many of those leafy greens into your diet as possible, and sticking some in into your sandwich or whatnot, is really just trying to simplify the process. And then, like Dr. Arts was saying at the beginning, staying away from those refined sugars and those simple carbs, and really just that more healthy fats, the olive oils and the healthy proteins as far as the salmon and the poultry. It's really these things that we've been hearing about for a long time as far as the Mediterranean diet is concerned. And now with the Mind diet, which is a combination of Mediterranean and DASH, I forget, what does DASH stand for again?
It's diet to stop hypertension. So it's like low sodium, relatively. So cardiologists would recommend the DASH diet. It's just a combination.
Yes.
Go ahead.
But the evidence has been really, really striking insofar as the Mind diet, specifically in reducing that risk of neurodegeneration. Mediterranean diet also has great research as well. But yes, the Mind diet is really something.
Help me out with these refined sugars.
As far as?
Some examples. What are we all eating that has all of these refined sugars that we probably should stay away from?
I'll go.
For it. Yeah.
Whoa, this is a hot topic when I talk to patients. So cookies, cake, ice cream, candy, as much as you can. Now, it doesn't mean you can't have it. It's just you want to reduce it way down. Processed sugars are bad for your brain. It's well documented. Sugar, bad. So cookie, candy, ice cream, baked goods. I know doughboys, stay away from doughboys. Whatever, I'm not picking on doughboys because I like things like that. It's not good for your brain. And what Persephone was saying, that in a nutshell, there's 10 good foods, 5 bad foods in the Mind diet. The bad foods are pretty obvious, what you would think, but red meat actually is considered a bad food in the diet, but chicken and fish are fine, right? And it's a very easy book. There's like a primer on the internet. You don't need to read the book if you don't want to. But the point is, abiding by it's the important thing. If you want to reduce your risk, and that's what the study showed, you have to abide by it as much as you can. It showed that it reduced the risk of Alzheimer's disease / dementia by 52%. Within, I mean, it's dramatic. If you were very strict with it, and like 36, 38%, if you were kind of partially strict about it, compliant with the diet, and there's nothing bad about it. Obviously, if you eat any food, you're going to eat, you potentially could have a lot of calories, and that'll make you gain weight, right? I guess if you had hundreds of oranges, you could essentially gain 10 pounds. But the reality is, watch what you eat for the amount what you eat. But the mind diet, there's nothing risky about it. There really isn't.
And what's really nice about it is it works on this point system, right? So you can, it really is about moderation and making sure that you're cutting out as much of those bad things. And I just, when we're talking about diet, you know, Dr. Arts mentioned in the beginning, this is all honest to goodness research. So ultra processed foods, a study about ultra processed foods. Anybody in here shocked that we shouldn't be eating ultra processed foods? Right? But there's now the evidence to show us just how bad. So look at things that are low in fiber, low in protein. That's what makes a food ultra processed. Processed red meats, our beloved bacon, right? 14% increased risk for dementia for having more than 2 servings of processed red meat a week.
Some of it also is like bacon has lots of salt in it, and salt increases your blood pressure. So if you ever had hypertension, by the way, anybody who has high blood pressure, moderate yourself when you go to Chinese restaurants. Less soy sauce, because that has tons of salt. It will jack your blood pressure up, and you don't want to have a stroke. I'm just being honest with y'all. This is what I do every day. Like, just try to control the salt intake, especially if you have high blood pressure.
You mentioned alcohol. Can you just touch on
Oh
that a
yeah.
little
So
further?
in the first, and I'll say 2 things. So in the first edition, which I wasn't part of at all, in the Mind Diet, which came out in 2017, Maggie Moon, who is the author, actually put a small amount of red. She had a glass of red wine on the front cover, and the reason is because there was some suggestion it had resveratrol in it, which is an antioxidant. It does. Red wine does have resveratrol in it, but the reality is you can't get enough resveratrol drinking 5 ounces of wine to do anything. So she's a scientific registered nutritionist. She wrote the second edition, as you see, if you can see the front cover. They removed it. It's colored blue, like blueberry blue. Call it blueberry blue, because blueberries are great for you in terms of high antioxidant content. But alcohol, there's really no reason to do this. Most people are drinking alcohol because either they do like the taste, or they're trying to appease, like in my experience, anxiety, depression, and treating their psychological issue or some undue stressor, and there's other ways to do that. There really is very limited evidence that any type of alcohol which has sugar in it is beneficial at all. You know, I know people drink it, they like to drink it at night. I literally ask every patient I see that if they drink or not, and the ones that are drinking, hopefully they're drinking a little bit. Really, there's no reason. And one last thing about alcohol, it can increase sleep apnea risk. So what happens is, if you drink alcohol at night, it relaxes your throat, which collapses the muscles. And so people can actually start snoring heavily, and you may have noticed this, whether you have sleep apnea or not. So it actually can exacerbate sleep apnea.
Why is my wife there shaking her head up and down in agreement? Telling tales on me. Goodbye, alcohol. Anyone like that news?
Brett, do you need to get a sleep study?
Perhaps, yeah. Yes, there is a correlation between alcohol and the snoring, yes. Yeah. Okay, where are we going with that? I think I'd like to open it up to the audience questions, but we just have a little bit of housekeeping. Is there anything we've missed that you want to add just before we...
I do have one thing.
Please?
Well, 2, but I'll say 1. So B vitamins, you know, people come to me and say, should I take B complex? There's no data that really taking B complex, B is important, B12 especially, and folate for your brain function, but there is no studies that taking super Bs is beneficial. Unless you're deficient, then we can say, I often check certain B vitamin levels in the blood, and if they're on the low side, yes, that's a reason to do it. People over-supplement themselves. And sometimes you can become toxic. People don't realize some of these vitamins can cause actually problems for your body or your brain. That's one thing. So vitamins. The second thing is that I don't think people, and this is very hard to say, and Dr. Crittenden was saying this also, it's not what you choose, it's to stay on track and do something. Because it's easier for me to say, okay, stop drinking and smoking, and I know how hard that is from doing medicine for so many years. Like, the risk of, that chances are very low statistically, but the first kind of 21 to 30 days is the time period. If you stick to your habit, there's a likelihood it's going to stick for a long period of time. So again, you got to choose your habit, you got to stick to it, regardless of what your lifestyle factor you're choosing to change is. That's the key thing. Because it's easy to read about this, like Dr. Crittenden said, but it's really hard to implement it. Sometimes you need a life coach. There are life coaches out there. You can hire them. There's lots of them.
Thank you.
Yep.
Do we have anything we want to
Yeah,
add?
I would
before
just
we...
add, so all of this, we've talked a lot about sleep, the cardiovascular risk factors, right? Everything that happens below the neck impacts what happens above the neck. Please look in July for the results of something called the U.S. Pointer Study, which is a lifestyle intervention trial that's actually putting all of these things together. We know exercise is good. We know sleep is important. We know food, the right foods. The U.S. Pointer Study is actually testing all of these together, in addition to cardiovascular risk factors like diabetes, high blood pressure, cholesterol, to see if making these lifestyle changes will have a reduction on your risk for dementia. We tested it in 2 different ways, and so there's going to be lots of emerging evidence that comes out to show not just the benefits, but how to actually implement them in your daily life. Because it is the biggest struggle, right? Making lifestyle changes is the hardest thing. So if you can make those slow incremental changes, let's just go for it.
And that's in July.
Yeah, July, the end of July, those results will be published.
So we'll have you back in September.
Love it.
Maybe. Awesome. So if you have a question, please raise your hand and the mic runners will come to you. Please keep your questions general in nature. If you have something specific, I'll ask you to come and see the panelists at the end. They are going to hang around for a little while. And please, no stories or comments. I'm sure there's lots of questions. We want to try to get through as many as we possibly can. So let's start over here with your question.
I'm curious about Lewy body dementia and how they diagnose that and how does it present? Does it present differently?
Who would like to take
Yes.
that?
So,
And please keep your answers as short as reasonable, just so we can get through as many questions.
okay. So Lewy body disease is a neurodegenerative disease, which means that the brain's losing tissue, and long or the short, it does present differently than, for example, Alzheimer's disease, and the fact that the part of the brain that's being affected is different. So in Alzheimer's, oftentimes the memory centers are first affected for most people. In Lewy body disease, people often have Parkinsonism associated, which means a slowing down of walking, or they have, for example, what's called REM sleep behavioral disorder, which means that oftentimes people are having dreams such as dreams of being attacked or chased by animals or people, or thinking or kicking or screaming or talking in their sleep. And by the way, if you do any of this, get a sleep evaluation, because it also could be sleep apnea presenting or masquerading as REM sleep behavioral disorder. So it's cognitive impairment, which actually it often has problems with attention, frontal lobe function, as opposed, there could be memory impairment. It tends to progress faster than Alzheimer's, and usually within the year from the time the person or family member is noticing the cognitive/memory impairments, there is a change in movement in some way. It could be a softening of the voice, it could be a tremor developing, it could be a slowing down of walking. And then another common thing is visual disturbances or hallucinations. So there's there's 4 or 5 main features. Actually, every day when I see somebody, one of my patients, I'm bringing this up because it's probably the second most common cause of a dementia, other than, for example, Parkinson's, which also can cause a dementia condition. So I hope that answered the question. And in terms of diagnosing, we can do PET imaging. There's a PET scan. We can ask Dr. Crittenden to do a more formal neuropsych evaluation, because there's certain, there can be certain patterns that show up that would support that happening.
Thank you. Great question.
It was mentioned that there are biodetectors that can help with, biomarkers that can help with early detection. Can my primary care physician order those with my regular labs? If so, what is it they order? And if so, how often should they order it?
Dr. Arts?
Yeah, so I'm going to just bring this up. So I just started doing, whether you want to know, so we can, there's something called, so there's biomarker tests that you can actually measure certain proteins in the blood. There's a company that just started kind of think about 2 years ago, they started offering this test for amyloid and tau in the brain. It's called Precivity's AD testing. It actually is not covered by Medicare or insurance. It's based on fee. That's an out-of-pocket cost depending on your ordinary income. I just started doing that for some of my patients about a month ago, actually. The reason to do that is that if some people have a syndrome that looks like they have Alzheimer's, there's ways to look closer, and that's one of the ways to rule in and rule out the problem. But it doesn't tell you how this is going to evolve. You get a number score from 0 to 100, and if the number score, say, is over 48, the chances are over 90%. If the number score is much lower, it makes it very unlikely. But I don't really order biomarker tests right now other than that. I don't do genetic testing. There's Quest Diagnostics. They would love me to order tests because they make lots of money. But what am I doing with the information? But that test does have some relevance because it can screen people in and out and people that have kind of a borderline situation with their complaints.
Is that an expensive test?
So the Precivity's test, if you make under $44,000 a year and you live alone, it's $50. If you make, and it's on their website, there's a table at the bottom under Financial Assist Program. It's based on your household income, actually. So it depends on how many people are in the house with you and then your ordinary income. And it goes up to $1,450 for somebody that makes, like, depending on how many people are in your household, anywhere between $169,000 up to $220,000 or more, it's $1,450. That would be the most you would have to pay for that blood test. Primary care doctors could order it, but I don't think right now they probably are. I am pretty much the only one that I know in Reno, or Renown at least, that's ordering that test.
Thank you. Over here.
So my question is, what's the truth about the brain supplement that you can get online, like Prevagen or some of the other stuff? Do you ever recommend those, or is that just a bunch of hooey?
If it seems too good to be true, it is. None of those supplements ever go through any sort of clinical trial to show that they have any evidence. So if you look at the ad during Jeopardy, which is when they oftentimes come up, it's very small at the bottom. What would you add, Dr. Arts?
So they spent lots of money on those really nice commercials, and I'm going to say 50% of the patients I see have already tried Neuriva Plus, Prevagen, or Focus Factor. Sometimes all of them. The reality is, like Claire was saying, there is no clinical evidence-based trials that support that they really are effective, but what's a placebo effect? A lot of people notice they have an improvement. If they feel better, it could be a placebo effect and the reality is if you want to spend $40, $60 and you think your memory's better and it started after you took the medicine, go off of it for a month, or sorry, the supplement, go off of it and see if there's a change. But the reality is I don't recommend any of them because the data is not there to support using them.
Are there any possible negative side effects taking any
I
of those?
haven't heard of
conjunction
anybody
with-
having any major complications or dying from them or having a heart attack or a stroke or something like developing cancer or one of the bad things that can happen to you. So I don't think there's no really major downside, but it's just there's no trial evidence. But we know there's such a big problem in the United States and people have a memory problem. That's why they have these out there. There's a market for it and people are buying it. They're buying it.
Michelle, where are you with the mic? Oh, there you are, Heidi. Thank you.
What is the use of the recall test? My primary physician has given me that annually for the last 3 years, and I think it's the easiest test I ever took. So it doesn't seem to be testing anything.
Are you talking about the mini-cog test? It's drawing a clock and remembering 3 words. That's pretty much all they can do. 5 animals. Oh, I don't know about that one. But do you want to talk about that?
I'm not sure what test is actually.
Oh, mini-cog? So anyway, it's the only test primary care physicians really have because it's easy for them to administer in the short time that they have. So long and the short is you can't diagnose dementia. If you go on the internet and website, there's 5 points you get. And so long and the short, it says if you have this amount if your score is high enough, you don't have dementia. If it's low enough, you have dementia. Well, dementia is a clinical diagnosis. It's based on symptoms. It's not based on a mini-cog test. So you need to see a doctor and go over symptoms and how they've evolved and what's associated with them. And are they affecting your daily life and your activities of daily living? Because if those aren't happening, you can't diagnose dementia. So one of the key points about this whole thing is you may have heard of what's called a mini mental state exam or a MOCA test, which is a more sophisticated test. I can't use that by itself to diagnose dementia. I have to ask about symptoms. This is why I spend a lot of time asking patients and their family members what's going on.
However, the important piece about perhaps that test that your primary care is giving, excuse me, is the screening process. And so, yes, you might be doing really well on it now and year after year, but if that changes, again, going back to change, then that's where something might be concerning, and then your provider can refer you on to someone to get a more detailed evaluation with more extensive testing or whatnot.
Yeah, I agree with that totally. So, so you can do these periodically, and if somebody is having more problems putting the hands on the clock, that's a risk, that's a warning sign, and then you really do need to look deeper. So it is a good screening tool, but you can't diagnose anybody. Even though on the internet and on that little primer it says rule out dementia or you may have dementia, no, because you can't use it that way. I don't know why they put it up there.
Question over here, but I'm just curious. How many other people have questions? Hands up? A few, not too many? Okay, good. Let's go.
Okay, my question is brain fog. After COVID was so rampant, we heard a lot about people having brain fog afterwards, but I never really learned what it was. And now I'm concerned, are the symptoms of that similar to the other symptoms that we might see with dementia? And can you explain the similarities or the differences between those two?
Back to you, Dr. Arts.
I will say this, which is kind of interesting. So I came to Reno during COVID, 2020. And so just finished my 4th year at Renown. I've probably seen 10 people where I'm pretty sure, I'm going to get to your answer, but 10 people where I'm pretty convinced that that was probably causing them some symptoms. But we don't have any way to test for it really, like spinal fluid testing. There's no really way to, you can say, yeah, I had a history of COVID. I was COVID positive tested, and I noticed my memory changed or my thinking changed. So with brain fog, just like with chemotherapy brain, chemo brain, which you may have heard about that for people oftentimes that had breast cancer treatment, or maybe they had whole brain radiation. The problem with the word brain fog is it's kind of describing a whole set of symptoms because it's affecting more than your memory. So you can have problems with concentration, reasoning, attention, short-term memory. So it is different than just a typical patient who is describing, I'm periodically forgetful for forgetting, like I go into a room and then maybe once a week I forget it. Or usually with what you're describing, it probably would come on within a couple weeks. It could be delayed. I don't have a lot of experience just because a lot of times I don't have a big clinic of brain fog patients that are complaining with that. But I do know it's different. And the symptoms are lingering and they're more global, and sometimes I have to rely on doing more sophisticated tests to get a baseline evaluation to see what the actual impairments are, because just because you complain of whatever, or the patient's complaining about this symptom, this symptom, this symptom, they have a history of COVID, clearly had COVID, right? There's not really a treatment, but it could cause impairments. Then it gets down to what do you do to reduce the impairments? So that gets a separate, so we're going down to risk reduction, right? Because you can't really treat the COVID brain thing right now that I know of. There's not really an FDA-approved medicine for that.
Sorry to go to Dr. Arts again, but it'd be so much more never mind. Anyway, so you addressed the issue of using a CPAP machine?
Yes.
And you started out very favorably, use that, and then you went on to something that I couldn't understand, and I thought it was maybe there are bad issues associated with using a CPAP. Could you go back to that?
There's
one,
no
please?
bad, so you can't, I mean, here's the thing, and I'm not a sleep specialist, but I do know that it can be adjusted if you have sleep apnea, and you can actually make the pressures going through the tube higher, and it could wake you up at night. That's why it's important to be following up with your sleep specialist, because you can adjust the numbers. But there's really no downside to using a CPAP machine. Some people just can't tolerate it because it suffocates them. You may have heard about the Aspire device, which is a stimulator that came out 2 years ago. You have to be you have to have specific, not everybody with sleep apnea can have an Aspire device if they can't tolerate the CPAP. Sometimes mandibular devices that a orophacial specialist can put, or a dentist is another way to treat sleep apnea. But CPAP is the most important thing. So I should have, if I said something that was causing problems, there is no, I don't know of anything where a CPAP machine will cause harm other than if it's not, if the numbers are adjusted incorrectly, which I would be surprised that would happen because you're seeing somebody who adjusts those things. Yeah. And there's also BiPAP. I don't want to get involved, but that's a different type of way. There's different types of mechanisms depending on the obstruction and how significant it is.
Thank you.
Yeah.
Kerry, over here.
Okay. All right, there we go. I've heard that it's really important to keep your brain active to help stave off this or kind of, slow the progression.
Do you have comments on that? How do we keep our brain active to
Yeah.
hopefully
I mean,
prevent?
I think that old adage of use it or lose it is so important. And even for people in the earliest stages of dementia and showing those cognitive decline, the more active they are seems to be better in how they progress or the speed at which they progress. So what's important about cognitive stimulation is doing something that challenges you, right? So if you're playing a level of one of those brain games or a puzzle and it's becoming a little too easy, challenge yourself up to the next level. Learn something new, language, a new instrument, a new recipe. Do something that really challenges your brain. But I think most importantly, you gotta like it, right? Because if you don't like it, you're not gonna do it. So find an activity that you're actually enjoying so that it doesn't become something you dread as opposed to something you look forward to doing. Would you add anything?
Yes, and if you can find that thing that incorporates both that cognitive stimulation as well as social engagement, social stimulation, even better, because both of those are so important.
Sounds like sitting in front of the TV all day is probably not a good solution.
Correct.
Not great.
No.
At Renown, I tried years ago to get important paperwork to Renown, and nobody could help me, like the durable power of attorney. What department, who do you call at Renown to get your stuff
So
going?
you should call your primary care provider because that's who's going to download the information.
And they'll get it to Renown. Okay, thank
Yeah,
you.
you call your primary, if you're a Renown, you get your care at Renown or through the Renown system. You can email through MyChart, right, the system. You should be able to do that. Or just call that department, primary care, and that's who should be doing that.
I don't have primary care at Renown. I have outside.
So if you have a specialist you're seeing, you can just, anybody should be able to do that. Any subspecialist. I mean, I'm a specialist, so we get that all the time because I see a lot of memory impaired
Somebody
patients.
at Renown, one of my specialists at Renown
They
can
should
help
be
me
able to do that. Absolutely.
Okay, thank you.
Yep.
Tell them Dr. Art sent you.
Yes. And it'll happen like that. Kerry.
Connection to the brain and the signals back and forth in this issue.
Mm-hmm.
And for example, I heard that incontinence can be one of the early signs of Alzheimer's.
Wow, that's a complicated question. In 1 minute to answer that. So I will say.
Let's go.
Oh, so yeah, there's actually centers in the brain that are important in urination and in the spinal cord. So you can have spinal cord problems causing urination issues, whether it's incontinence, increased urgency and frequency, which prostate. So in a male, prostate issues would be a common thing. But I've seen a lot of people who actually went and have, they're on Flomax or whatever medicines, and they're still having issues. And then it gets into, are they having memory and thinking problems? And then you bring up the issue of urinary incontinence. So there's lots of causes for that, but I will say that when somebody has a dementia issue, especially with Alzheimer's over time, in some stages the brain's degenerated enough that they lose it's called micturition center in the brain. You lose the capacity to know when you need to urinate. So one of the stages of Alzheimer's at some point is actually bowel and bladder incontinence. Now that doesn't mean you have bowel and bladder. If you have urinary incontinence, you have Alzheimer's disease because there's many causes for that to happen. That's a primary care issue you need to talk about.
Thank you. Michelle, where are you? Any questions on this side? Over here. Kerry's got it. Any other questions on this side before we wrap up? We'll take this one last question. Yeah, please go.
Yeah, Dr. Arts, Do you recommend that my wife and I both come in to visit you at the same time? Would you treat both of us?
Wow. I'm not sure I need to treat you unless I know something's wrong with you.
Oh, okay.
You seem pretty good to me, but anyway,
Well,
I don't want
thank
to
you.
make that. But yeah, I have actually couples come in one after the other. I can sometimes joke, but it's not like, I just say like so I have people in their 90s that see me, and this reality is people in their 90s are going to have memory problems, but some people are worried they have Alzheimer's, and if you have a couple that's in their 90s, or I'm just using the word at 90, could be 70s or 80s, but I probably, yeah. So the answer is yes, but it has to be not at the same time. And if you both have memory problems, bring somebody with you, because I have to rely on somebody to give the history if it's that bad. So bring a third person.
So 2 separate appointments, no 2-for-1 deals. That's what
We
I'm
don't
hearing.
do 2 for 1, but we do have a Starbucks downstairs on the bottom floor where I work.
We've hit 11:30. I just want to thank you all so much for taking time to come along and learn and be educated. Annette's coming up here with a question, a comment before we... Oh, Annette just wanted me to let you know that if you wanted to replay any of this, it is recorded, gives about a week or so, and it'll be on the website, the Retired Living True Series. .com, top right-hand corner, past events, and you'll find all the recordings of all the seminars if you wish to go back to any. And again, if you'd like to attend any of the future ones, please complete the evaluation form. And just a big round of applause for yourselves and our wonderful panelists.